Okay, good morning, everybody. I'm Councillor Jody Stoll, the chairman of the committee, and I would like to welcome you all to this meeting of the Adult Social Care and Health Select Committee that is being broadcast live and recorded for publication on YouTube. Okay, we'll move on to agenda item number 1, which is the minutes of the last meeting. And if we could approve the minutes of the last meeting with a show of hands. Okay, thank you, everybody. Okay, apologies for absence. Martin, is there... Sorry, James. Any apologies for absences?
With your permission, Chair, we have a few to get through. So we have apologies from Councillor Jan Gould for other reasons, Councillor Roger Jackson for other reasons, and Councillor Brian Wheatcroft on medical illness reasons. Attending as substitute members today, we have Councillor Kevin Brown for Councillor Brian Wheatcroft, Councillor Stephen Pearson for Councillor Roger Jackson, Councillor Jim Vernon for Councillor Jan Gould. And just also a note in the change of membership of the committee, it was noted that Councillor Richard Darrington has replaced Councillor Simon Wright as in this committee as of the 27th of January of this year. That's all, Chair. Thank you.
Thank you, James. And I'd like to welcome Councillor Darrington to the committee. Thank you. Councillor Answer.
Yeah. Thank you, Chairman. Councillor Kelvin Wright, he can't do it because he's got work commitments.
Thank you. Okay. Okay, moving on. Declarations of interest. If any councillor or officer has an interest in any matter on today's agenda, you should declare it now. Please raise your hand now if you have an interest to declare. If you have an interest to declare, you should state what type of interest it is, and please give brief details. Okay, thank you very much. And moving on to agenda item number 4, which is page 11 of the agenda pack, and that is the care quality and assurance of adult social care in Nottinghamshire, regulated services, social care market oversight, care quality commission assurance, and internal audit activity. Bit of a mouthful, but there we are. Councillor Answer, would you like to present the report?
Well, I'll just move it forward if we could just present it to one of the officers. It's been my information. I'm sorry about that. Yeah, I'll present it, but the officer is going to go into the report in some detail. Thank you.
Thank you, Councillor Answer. Okay, over to you, Katie.
Great, thank you. Really pleased to bring this item today. It is quite a big report with a big title because we have a big care market in Nottinghamshire. So we have a statutory duty under the Care Act to make sure that we have a sufficient and sustainable market. And we do that in a whole range of ways. We have to understand the needs of people now and the future needs that we are predicting. We do that through looking at our population, needs analysis, talking with people, talking with our provider partners to be able to plan and shape our market. And we do have a sufficient and sustainable market in Nottinghamshire. We also have to make sure that care and support is of good quality for people when they need it, and that they don't have to wait to receive the care and support that they need. So this report sets out how we make sure that the care and support people get is of good quality. The majority of care and support that is provided to people in Nottinghamshire is through external providers. They are our partners, and we work very closely with our providers. We also have a big range of self-funders that draw on care and support in Nottinghamshire that don't want or need to come to the council as well. But we need to be aware of that because we have a duty to make sure that there is enough care and support for everybody that needs it, even if you are somebody that doesn't come to the council to have that arranged for you. We also have a lot of information about other local authorities and other health organisations that use care and support in Nottinghamshire as well. So that's quite a big, complex market. So we have approximately 488 providers that are registered with the Care Quality Commission. So the Care Quality Commission register providers and they have to regulate the market. So they go in and they first of all will make sure that a provider is able to be registered to provide the type of personal care or care after an injury, a whole range of things that they need to do, and that they have trained workforce. And then they will go back at certain times to regulate and check that that quality is okay. And they will give the provider a score, which is inadequate, requires improvement, adequate, good, outstanding. I'm really pleased to say that in Nottinghamshire, of the care market, the care providers that we contract with, we don't currently have any inadequate providers, and we have a really high proportion of providers rated good or outstanding when we compare to other local authorities across the country. We are above national average. Part of that is because we invest and make sure that we are doing a lot of work hand in hand with our providers to keep quality up, or to be able to spot when quality is declining and go in and do something about it, which I'll describe. As well as having a whole range of providers, our external care workforce, with the deep dive work that we've done, we estimate to be about 23,000 people. So this is a really important workforce for us. And we have lots of information and some stats in the report for you on that workforce. So we need to make sure that there's diversity and choice in the market when you are wanting to draw on care and support, and that the quality is good. You will have heard of lots of different types of care and support, like residential care, home care, people that go into your home to help you with personal needs. And you might have heard of a range of things like day opportunities. Certainly our day opportunities strategy has been to select committee before, where we've been shifting away from just being in buildings and doing day activities, predominantly with people that have a learning disability and or autism, through to creating communities of people that meet at places that are important to them, doing activities that are working towards the goals that they've got to live their what we call gloriously ordinary lives. So we have a whole range of different types of support. Some of that is listed in this report. There are issues in our market, and we work in a partnership way. So providers tell us that it can be really hard to recruit, it can be really hard to retain staff. So we have something called the Nottinghamshire Care Association, which is an umbrella organisation that works with a lot of our providers. And we work in partnership with the NCA and providers to look at how we can support recruitment, retention, some of the training needs. So we've put in a whole range of training over the last year to 18 months. We've pulled funding for that from external sources, and some of it has come from our public health budget within the council to be able to provide things like mental health, Capacity Act training, and a whole range of things. And we've got that listed in the report. We also do lots of partnership sessions and events throughout the year for providers that have a range of themes, and that might be looking at safeguarding, it might be looking at digital innovation, how to support people differently. So we do a whole range of things together, which is all part of continuing to grow and support a market that is providing really good care, quality and choice for people. So I'm pleased to say that if you do need care and support in Nottinghamshire, generally you don't wait. Generally, we are really fast at putting that care and support into place. Our market is sufficient. We do have some areas that we don't have enough of, and you might have seen information about we're always trying to increase supported living for people to have their own front door and have care and support going in. We have had too many people going into residential care. but we've worked with external developers. We've been able to move over 100 people into supported living over the last year that would have gone into residential care if we didn't have that. And actually a third of those people stepped down from residential care into supported living, which is really positive in terms of maximising independence for people. So that's the main area. And extra care, which is a home for life for about 50% of people over 65 that might have gone into residential care. Extra care is a different kind of support with your own front door, and again, care coming into your home that is not as full support as residential care. So they're two areas that we're trying to develop more of. But apart from that, we have very sufficient amount. We actually have too much residential care, and that's important for us to understand across the county. Because when we see vacancy rates being quite high, that can create some issues financially for providers, which can also impact on quality. So we do watch that shape of the market, what is happening in terms of where we might have an over provision, where we've got under provision, and how we keep the balance of need and supply in that sense. So we do lots and lots of work. In terms of the range of things that we do to directly support quality, in addition to training, we do a whole range of things. Gemma Shelton has a joint team between ourselves and the ICB so that we can look in a holistic way about care and health support and quality. We audit all of our providers at least once a year. We are really, really working closely with our providers. We also do a lot of intelligence sharing. So we have weekly intelligence sharing with our operational teams. We have monthly, 4-weekly intelligence sharing with our partners. So that includes the CQC regional teams. It includes fire and rescue, housing, city council, the ICB, the health family in general. We do lots and lots of sharing in that sense. Things are escalated to us in between those 4 weekly meetings if needed. So we have a lot of intelligence sharing. We have a whole range of dashboards. We even watch things like when a registered manager changes in a care home. We know that that is an important time to look at whether quality sustains, improves or declines in terms of manager changes. And we also work closely with trading standards. We've created an audit tool and trained our trading standards colleagues because they're going into lots of sites across Nottinghamshire and are also able to be early eyes and ears for us. And that's been really important. We have lots of events. We've created a range of communities of practice. So I've just talked about digital innovation. We have a strengths-based community of practice. We have a community of practice with providers on supporting people with a learning disability and or autism. So we've got a range of places where we are talking about best practice, sharing good ideas, etc. So we have all of that information. We also make it very clear and visible that if you're part of our care workforce, you can come directly to us in a whistleblowing manner to come and anonymously share information if you are seeing something that you're not happy with. And we try to be as visible as we can for families to know that they can come to us as well. So we have a whole range of ways to talk to us and an incredible amount of information on our dashboards. When quality does start to decline, we have a really good reactive approach as well. So building on all of that proactive work. Proactively, when we start to see quality declining, we will be in early with a provider. We will have an action plan. We'll be upfront and honest about what's not going well, and we will agree what needs to happen. And generally that works really well, doesn't it, Gemma? That we tend to see then an improvement. And that might be we've visited and seen that there aren't enough staff on or something in their policies and procedures isn't happening. Or we will go in and we will look at everybody's care plan and make sure that we are talking with people and getting their views, but also observing, are these things that are in the care plan actually happening? Are we seeing all? So when, or intelligence that comes to us that things aren't quite right, we do that early work. So we have action plans. We might get into contractual sanctions where we say, we're worried about this. You are now not allowed to accept any more people into your care home until we've managed to get to an improved position. On a reactive basis, if things are declining, we can have teams on the ground, and have done this many times. We can have teams on the ground that are our own teams from our operational teams and our quality support teams. Plus we can pull in health teams really, really fast. So we can have people on the ground with a provider very fast. Sometimes we've had to put that in terms of 24/7 whilst we do a really big medicines audit, for example, and go around and check that everybody is safe. We can sometimes be, sadly, at that level. We have experienced that, where we have reviewed absolutely everybody from a health and care perspective to check that they are safe, things are happening. We've put additional staff in, and we have got some really fast things that need to improve. We've also brought people in that might be a health specialist in terms of medicines training, infection control training, so we can do things really fast. And what we tend to see is when we've got a management team that are really open to that and saying, yes, we understand and we see these issues too. We desperately want to improve this situation and we will work with you. We do see quality improve. We have had occasions when quality hasn't improved fast enough, or the provider has taken a decision, which sometimes has been for financial reasons, that they need to exit the market. So then our focus becomes keeping people safe, making that change for people be a positive change, a careful change. We look at every single person, we work with families and make sure that we find an alternative that is better for that person. And we have got lots of stories of difference where we've seen people really flourish after a move as well. So I'm going to pause there, because that's quite a lot of information, and I know the report's quite big.
I think obviously I've been able to go through this week in, week out, and we are making vast improvements within adult social care, and particularly with people staying in their homes as long as possible and having their own front door. That's so important. So on the basis of that, I've got nothing else to say. It's about questions now.
Okay, thank you, Katie. That was a really, really detailed report, and so you did that without any presentation. That was pretty impressive. So thank you. Is anybody else anything further to add before we open the floor for questions?
No. I'll reserve the right to have, at the end to make a few comments, if that's okay.
Yeah, no problem at all. Okay. Okay, can we move the recommendations? And seek a seconder?
Yeah, I'll second that.
Thank you very much. Okay, and I'm going to open the floor for debate. So, usual rules apply. One question and then a follow-up question, and then we'll move around, and then if there's time, then we'll come back to anybody. Okay. Okay, Councillor Cox.
Thank you. I just want to pick up on something on the training side of things. We're investing a lot of money in the training of outside staff too. So we've got the staff and the training. And you're saying the cost is coming out of funding from the council. Do we get these trainees any contract signing to say that once they've had the training, they've committed to being with that particular environment for a period of time, or are we open that they're staying and we have they have no contractual obligation to stay behind after the training?
I'll just come in first and I'll bring Gemma in. So just thank you. Just to clarify, our external providers mostly pay for their staff to be trained, qualified, supported. That comes out of their budgets because they are their own businesses. What we've done is a really big, we spent about a year doing a deep dive into our external care workforce with Skills for Care, national organisation, looking at understanding the makeup of our workforce better, understanding the biggest issues for our providers, which did, and what our workforce would say, which were recruitment and retention, being valued and recognised as a workforce, and we see that nationally, and we often don't see the social care workforce talked about as much as perhaps the health workforce, for example, and they were kind of the key things that they were saying, and career progression. So in response to that, we created an external workforce plan, which was about how to respond to those things. From that came our amazing Proud to Care Awards, which we do once a year. We've run for 2 years now. And that is where we have insourced a lot of sponsorship. We have a big event, people win awards. It's absolutely brilliant. And that's about raising the profile. But then the training, so providing the training after doing that auditing and deep dive work. So mostly the training that you would need to enter the workforce and be qualified to the right level, your employer would do. Over the top of that, we brought in an amount of money from the RAIN Foundation, didn't we, which was external funding, and have spent it on some of the training that you see in the report. But also there's been a link with our public health work in the council. So there's been some money from public health to help roll out training that we want to get out to our children's and adults workforces as well. Gemma, do you want to just come in on the contract bits?
Yeah, just to confirm, we do not have the staff sign any contract. But what we do, unless it's specific funding, as Katie said, around RAIN Foundation, if it is council's money as such, we do actually charge providers as well. So we do bring in some income, then we can do more training. So we do that as well. So, but unfortunately, we don't get the staff to sign any contracts because it wouldn't work. And actually, us monitoring that and us keeping on top of that, we wouldn't be achievable. So we do charge a lot of the time as well. So.
Just confirm on the budget, historically what happened was you used to get a grant for assisting the market, and that's been rolled up now into the base budget. So actually it's a grant, it was a grant, now it's in the base budget, but it's money that comes from the government to enable us to do this work. So it's not as if we're taking money from elsewhere in the council to go to this. I mean, the other thing I would say is care is a career for people. So it's not like going to work in Sainsbury's and then you think, oh, I'm going to get 5p more and I'm going to go then work in Tesco. People generally commit to wanting to work in the care market, and they've always been paid lower than actually they can do in some other industries. But we know by giving good support that people want to stay because they choose to do that, really. And we encourage that to be a career.
Thank you for the response, and I fully understand the career decisions of the caring community. My only concern was that, you know, if we're funding individuals to get that training, and then they decide to leave that particular venue where we are supporting and go to work for a private company that's making more money because they're charging private sector, you know, we're funding people to go out and businesses to make money, and it's costing us taxpayers money. That was my concern there. That's all. But I appreciate it. Thank you.
Councillor Gurley.
Yeah, thanks, Chairman. I'm looking at the graph where it says what does the workforce currently look like, and it would appear from that actually the retention rate is quite good. So I would imagine that part of the way they're cared for would be in helping with that. Bit of a complaint really. Can we raise the 65 up to 70 because I fall within the bracket? I'm not particularly pleased about that. But also this chart I'm looking at, bearing in mind this is for adult social care and health, and things happen like you have to start wearing glasses, it's not in focus, and when it's printed it's not in focus. It would be really handy because I cannot read the demographics at the bottom line. So I've got no idea what those boxes mean or show. But the bits I can read, it's really interesting because, you know, the Happy to see the average age is quite low, which is good because they tend, keeping them longer, aren't you? So there's some really good stats there, I think, which shows that what you're doing is actually working. So it's sort of, even though I've moaned, I'm sort of saying well done, if that helps.
Sorry, Councillor Girling, which page are you referring to?
Take it, sorry.
Which page were you referring to? Of which page?
Oh, sorry, page 27.
Page 27.
Yeah. Yes, what does the workforce current look like? And I've got a printed off copy here, and it's blurred on my screen. I've expanded it to have a look, and you can, well, if somebody can read that bottom line, please tell me what it says because I can't read it. But it would, it'd be interesting to see what those are. To be fair, but yeah, I think the way you do it going about this is the right way to go about it, and that's what I'm saying. So really, thank you.
Thank you. Councillor Rich?
Oh, that's all right.
Yeah, I've got a bit of a question. This one is kind of about section 42. The council addressed the concern attend to section 42 safeguarding referrals for ageing well care homes, particularly those related to neglect and physical abuse.
Were you asking? Sorry, just clarifying. Were you asking us to talk through the themes? Yeah. Okay. So, providers, the biggest referrals for safeguarding tend to come from providers, don't they, Emma? Or certainly.
Yeah, they're one of our largest referrers in for safeguarding concerns.
So providers will need to escalate things to us appropriately, and under the Care Act it's set out why and what. We keep a whole track of the themes of the safeguarding referral that are specifically coming either from providers or are safeguarding themes about a provider. So we look from both of those lenses. So when they come through to our multi-agency safeguarding hub, our MASH, we understand and throughout the year are watching the themes that are coming through. So in terms of themes coming from providers themselves, we can then talk with our Nottinghamshire Care Association or a specific area of the market, might be our residential care homes, and talk about some of those themes together. When it is themes about specific providers, that is a trigger for us to be having a look at those providers as part of our quality work that we're watching. As well as that, we also know that there are too many referrals that go through to the MASH that actually aren't about safeguarding, but providers perhaps weren't too sure where to go to get a fast enough answer. So we've worked hand in hand with our providers and created a non-safeguarding channel. So providers want some advice on something or are unsure, they can come through that channel. And I can't remember the numbers, but it's about 300 referrals a year, probably more than that now. It's been a really effective way of things that are not about safeguarding coming straight to Gemma's team and not going inappropriately to our safeguarding referral place.
Just in case for people who don't know, section 42 is actually the part of the Care Act which refers to a referral that's come in about safeguarding that requires us to investigate or look into it further. So that's what the section 42 means. And the MASH is the multi-agency safeguarding hub, which is actually in this building as well, really. Just so that.
Thank you. And just to add to what Katie was explaining in terms of our different mechanisms for managing those themes, understanding what's happening and how we can react quickly. In terms of when concerns do reach a safeguarding threshold, so in terms of needing social workers to go out and to take those inquiries, social workers then would do that, particularly if we've got concerns about neglect, and often that can be something from missed medication to somebody not being kept, well, sort of fed, and all of those elements. It does continue to be an area of concern for us, and that feeds into the additional training and support that we've been providing for care providers in terms of making sure that the workforce got the skills they need to do the work. And then where there are concerns perhaps about staff training or number of staffing, that's when our provider improvement team and Gemma's area of service will go in and provide that support to the manager of the service and really make sure that we've got the appropriate levels of staffing in there. So it's a two-pronged approach in terms of contracting and commissioning element of that, and then also the hands-on social work element of that as well.
So sorry, just to add one more bit, that is just really nice to be able to share is, I don't think he'd mind being quoted, but our independent chair of our adult safeguarding board a few months ago now did say, because he works across a range of places, that in Nottinghamshire is where he'd seen the greatest oversight of our market in terms of quality and understanding what's going on, and that's really nice to be able to just share that in this context.
Councillor Gowland?
Thank you. Thank you. At the end of your presentation, you talked about providers leaving the market. Could you just say what fraction of the residential and non-residential providers have left the market?
We have seen, I think how many care homes, about 8 have actually closed in the last year, very long, 18 months.
Now, because this, it's probably 8 in the last 18 months.
Yeah, the last 6 months have been, saying it out loud, have been really stable. And before that, we actually had seen, we'd seen a few, about 20 care homes in the year to 18 months before that, where there'd been some difficulties. And probably about half of those we supported back, and they were really keen and really passionate and invested and did everything they could to improve, and we saw some really good improvements. But probably about half of them exited the market, and we would have supported that was the right decision. In terms of under 65s residential care, actually, we've had some providers not exit but change in a really positive way. So we've seen 3 care homes have converted to become supported living, and that is part of understanding and us working together to say actually we need less of that and more of that, and have had a close enough relationship to be able to navigate some of those changes, and we'd like to see more of that. But it tends to be in the residential care area that we see more exiting.
So,
just give a clarification point on that. I think it's important to understand that not all homes close because of poor practice or poor quality. Some exit the market because it's their time to exit the market, because some people have chosen that they no longer want to be in business and retire and those sort of things.
so does that leave any geographical holes with those? You can't control that obviously with the market, but
we absolutely do monitor on a geographical basis. Have we got, because that is part of the being sufficient and sustainable. So we do keep an eye on that. We have sufficiency generally, apart from the caveated bits around we need more supported living and extra care across a whole range of areas, and we have a clear needs analysis. Residential care with nursing care in mid-Notts and in the north, we became quite thin for a while, but part of our work, our commissioning and market shaping work, is to be understanding that, and again being ahead of that, and being out talking with providers about increasing some of those things. So we haven't been overly worried, but we do notice where we might be getting slimmer, and we are proactive about that. We have a market position statement. That's a document that all local authorities should have, which is where we have all of that business information for providers, and we've been updating ours. We've got a new one that's about to go out.
Councillor Pearson.
No, sorry, that's me. Yeah, just on paragraph 12 of the report, looking at the vacancy figures there, it looks like about 12–15%, which potentially is quite serious for providers because many of them will claim, rightly or wrongly, that they're operating on wafer-thin margins. So, you know, they aren't sustainable with that sort of level of vacancy. I'm just wondering, in situations where perhaps residents have to move from one home to another, whether that's something that you get actively involved in and how you go about that?
Yes, yeah, we definitely get involved. So part of our process within the contracting team is to work with providers on that. So we, from the point of us knowing that a care home or a service is closing, whatever it is, we get involved and make sure we have relatives meetings, etc. And we offer support. The people that are funded with Nottingham County Council, we will pull in Emma's teams to help with those moves and help families find a new home. If it's people who are self-funding and funding their own, we do also offer help to move. So they wouldn't ever be left to sort of manage that move on their own. It would be part of the process that we bring in. It's called our closure process or escalation processes. So it is part of, as soon as we know, we make sure we've got that communication in with families straight away.
Okay, thank you.
Just add to that though, I mean, it's useful to know as well that last year we spent £29 million on investing in the market to enable them to be able to pay fair prices for people to be paid. That was higher last year because of the national insurance rates that went up and the living wage. And again, this year we'll be doing a further 12 million through the budget to make sure that people have got adequate money to be able to pay people well.
Councillor Cox.
Thank you, Chair. I just want to go back to paragraph 6 of the report. So I know we're going backwards and forwards, but it's just you mentioned about the audits that we conduct on these premises through either CQC or Nottinghamshire. Look, I'm more interested in the Nottinghamshire side of things. Are these audits planned or are these snap audits?
Okay, I'm going to talk about two different things. So we've got nationally the Care Quality Commission, CQC, who go in and regulate. CQC do a really important job. It's been very widely known that CQC have struggled in terms of a backlog of going in and inspecting providers, and they've got their own improvement plan in place, and we're starting to see them moving forwards. They've been very open about their improvement plan. So that does mean that in Nottinghamshire, like many other places, there have been a range of providers that haven't had that official regulatory visit from the CQC for a very long time. That's why it's really important that as a council, we have got really good oversight of our market. So yes, we do have annual audits of our providers, but based on our intelligence, based on what we know about providers and intelligence coming in, that some providers are running really, really well and we are worried about some, we will quite often go in unannounced where we need to. So we do that quite a lot. So CQC will go in unannounced as well, but because it can be quite a long time between some of their visits, and they work on a risk-based approach as well. So if they get intelligence that triggers their system, they will do an unannounced visit, but we do that as well.
That's great, thank you. I much prefer the unannounced than the announced. Thank you.
Yeah, if I can just put some peace of mind there. I have visited a number of care homes within the district, and in particular, I went to one and they've not had a CQ inspection for 7 years. But the report was there that we'd done our annual inspection. So at least we do check from our own point of view that the care and the quality that's in that care home is good. And I think that gives us reassurance that where people are, they're being looked after and being looked after well. And I think the other thing is when I've gone into these nursing homes, I have actually spoke to the people that's in there, at the care homes, or wherever I've gone, I've more spoke to everyone, and I always ask them what they think about it. And I can honestly say this, not one person has turned around to me and said anything negative. Not one person. They're all positive about where they are, they love where they are. And, you know, that's got to be, you know, down to the service and down to the officers in all these inspections and being able to check everything out. So I can reassure you, myself point of view, I've actually been in, seen it, and it's good. Thank you.
And just to add a bit more assurance in terms of the quality that we triangulate, it's also about the social workers day in, day out who go and do the reviews of people in wherever they're living. So they see it from a different angle, and we'll be doing individual work with that individual to make sure their care needs are being met. Also, we encourage families or friends and families to encourage and give us information, and they are part of the review. So we ask them about how they're seeing the care that they're receiving for either their loved one or family member. So there are lots of ways in which we triangulate information to enable us to ensure that people keep safe and sound.
Councillor Vernon.
Yeah, thank you. You've actually almost answered the question I was going to ask. But basically, I look down here and I see one of them with a rating that is 6 years old. How can it get to 6 years old? I know somebody just indicated that you have your own team that will look at it, but shouldn't that then filter through to here so it doesn't look like we've got a 6 years old red warning on somebody?
That's the national CQC visit date. They are the national regulatory body. They've been very public about the fact that they are behind, and that has meant in some local authorities there are providers that are 6-7 years out of date. That's really difficult because from a quality perspective, it's also difficult for providers that might have had quite a negative rating in the past and have done loads of work, and quite rightly want to be showing what a great organisation they are. So it matters from a whole range of lenses. CQC have announced their improvement plan. We've got a great relationship with our regional team, and they've got some more resources now, haven't they? So we're hoping to see those gaps close in terms of the CQC visits, but it's something that we do need to keep watching, and every time we come here we will bring that information for you. But it goes back to why it's so important that we're doing our job within this really regularly, and keeping an eye on that. And also within us being close to our market and our providers, they are such crucial partners for us in getting things right for people. Having such close oversight and working relationship also means we're spotting the best practice, and there are loads of opportunities for people to talk to us about good ideas so that we can breed and share more of that as well. And we have so much passion out there, and people want to do a great job for people.
Yeah, thank you. That's quite comprehensive. But while I've got the floor, the second part, and then it says coming back to me. There's 2 care homes currently under default notices, and then I read about voluntary placement suspensions. I'm new to this, so if you could just explain that to me in layman's terms, please.
Yeah, no problem. Basically what that means, it's part of our contract, and it's obviously got a number of stipulations. So when we get to the point where we've evidenced, and it's all around evidence, what we found and what we see through the visits, when we've got to the point where they've defaulted on their contract, we issue that contract, what we used to call is contract suspensions. So basically what that means for that period of time, as Katie spoke about, we've got an action plan with that provider, but to help them put those actions in place, we say to them, it's normally for care home, it's all for care homes, home care, etc., is that they don't take on any new people, so new placements, new home care packages of care, etc., during that period of time. It's normally 6 to 8 weeks initially, and we extend it as and when we see the progress or not. So yeah, and the numbers are relatively low at the minute with providers under those default notices.
Very clear. Thank you very much.
Okay, yeah, I have a question. So really it's around, well, there's a couple of parts to it. So obviously we've got the CQC inspections and we do our own inspections. And obviously in absence of a CQC inspection, if we're sort of 6-7 years behind, it could appear that we're kind of marking our own homework. So really my question is around does our inspection or does the council's inspection regimen mirror the CQC's? Are we more robust? Are we less robust? How does that work? And could you sort of inform the committee what is the scale of the CQC backlog across Nottinghamshire, just so we have an idea? Thank you.
Okay, in terms of are we doing the right things? So, as many of you will know, as a council, we have an internal audit process. And when they've come out to audit our teams and our processes, we've had a very high rating, haven't we? Which is not easy to get from an internal audit team. So we have some validation there. There is some of this that feeds into our adult safeguarding board, and obviously a connection with our independent chair, who takes a view of how well we are managing risk in our market in a safeguarding sense, and really nice to be able to share his comments about how close our oversight is. We've also trained our trading standards colleagues. So again, it's not just our teams that are going out. We've got intelligence coming in there, and we work with our partners. But also, there are routes that providers can put in a complaint about the way that we're operating. So there are routes for providers to come back and say, we're not happy with that, which doesn't happen very often, but does happen. And then we can have a look at that and respond to that. And sometimes that is about, it feels really hard when we have just arrived unannounced and are quite robust. It can feel quite robust about what we're looking at. And that has been felt in some places. So I think there are a range of ways. The CQC regional team themselves will share intelligence back with us. And I think we've got an open and honest enough relationship where if they weren't happy, they would tell that to us. We certainly have had conversations in the past when we went through that period where we had quite a few care homes in a row that were struggling. Now that CQC are increasing their presence again, they have given us some informal feedback that they've really seen the quality work that we've been doing. So that's been nice to hear as well. So hopefully that, have I answered everything? Oh, the scale of CQC backlog.
So in terms of numbers, I can't remember the exact number, but there's around 100 in terms of what the CQC locally saying are their priorities, and 100 services, sorry, and that's for the whole of Nottinghamshire. It won't be just our contracted services. So those 100 services will be made up of those that have not rated yet. So there'll be a number of domiciliary care services more than anything that have been registered with the CQC but haven't had their first inspection. And then there'll be a number of services that have got old inspections. So anything around probably 4, 5, 6 years, they'll be on their priority list. So they've got around, for Nottinghamshire, that's just the Shire, they've got around 100 services that are on their priority list, and they have got a specific team within the CQC that are going to be going out to those services first. They will still be doing their risk-based approach, because that's what CQC have been doing in previous years, is basing their inspection on risk rather than length of inspection. But obviously with that, we've got the services Katie said that are obviously 4, 5, 6, 7 years old now. So we are starting to see CQC go out. We're seeing inspections coming through. So we are seeing that positive work happening with the CQC. But I suppose just in terms of our audit tool, Nottinghamshire County Council, from an adult social care contract, we have got our own audit tool. Whilst there's some elements that you may see within the CQC inspection, we base a lot of it on our contracts as well and on our care responsibilities. So it's a very big, robust tool, and obviously we've got it's one tool, but obviously it changes slightly for each of the services. So it's not the same, but there will be elements that are very similar within what CQC do and what we do, because we're in the service and looking at people. So it is that same sort of process.
Councillor Brown.
Thank you, Chair. Mine's more a question of home care. Excuse me. After looking at the tech display upstairs, tech-enabled care, have we seen any measurable benefits in reduced hospital admissions, delayed care placements, and improvement in independent services? Have we got any measurable figures?
Yes.
Yeah.
In the tech report, which is next, we have got some stats for you where we're using tech. Shall I save it for that one?
You can.
Yeah.
Yeah,
Sorry.
so, yeah,
Yes.
we've
First
got
time I've been on this.
no,
Yes,
it's fine.
absolutely, and we do track where we are supporting people to. Most people want to stay at home, and we do a range of things to try and support them when that is the right thing to do.
You can go first, Kev, on the next section. Thank you. Any further questions? Sorry, I didn't. No. Okay. Okay. In that case, then, can we take a? Oh, sorry. Yeah, I'm jumping ahead.
Just to add a comment which has not been made. There's always the opportunity for the staff in the care homes to whistleblow. In other words, report issues that they dare say, but they come and tell us. And we've had that, haven't we?
Yes.
People whistleblowing, and then they're always looked at. I think that to remember that as well. So we've got people in there that always have concerns about practices or about anything that they can whistleblow, and it's always looked into.
Yeah. No. Thank you for that. Guy. Yeah.
Thank you. And just to add to that, people are protected if they whistleblow. So we do encourage people to do it, so there won't be repercussions for them if they do. Can I just add a few points to the conversation, really? One is to just raise awareness around safeguarding, because actually people may or may not know, but quite a lot of people move into Nottinghamshire because we have such a big market. And that means that we then have people from around other counties, other places that come and place in Nottingham, and we have the responsibility for the safeguarding of those people. So quite a lot of our work. So I think about 60% of people who live in care homes for younger adults are from outside, and about 70% for older adults are from outside, so not by us. So actually there's a lot of safeguarding activity that happens that is just because we have such a big market. You've got a question, I can see. So yeah, we only use 30% of the older care market and only 40% of the younger care, residential and nursing I'm talking about now. So there's a whole lot of people that are placed from elsewhere, many from the city, but also from Derby and elsewhere, really. So, but it's our responsibility to do the safeguarding around that, which is why we have a big safeguarding function to be able to deal with that. That's the first thing I was going to say. I think the second thing to say is we often talk about people who are placed within the county. We also place people outside of the county, and it's to make sure that you're aware that one of the things I have on my worry list is making sure that those people are seen, because you'll know from previous panorama programs and ITV dramas or whatever, that actually it's those people that are not nearest to us that are mostly main at risk, really. So I make sure that we do to stay on top of anybody who's placed outside of the county, that they're seen, and that we make sure that they're safe as well, so that we don't fall into any of those traps of not seeing somebody for a long time. And the other thing I'd say is a lot of people are self-funding, and Katie mentioned this at the beginning, but people will come into your surgeries or you'll come into contact with your constituents. I think it's really important that they have the right information and advice, so even if they're not going to use us, getting information and advice from us to be able to make sure they make the right decisions on what home or whatever care they need is really important, because actually we want them to know that actually there are good places and there are not so good places, and actually if you're going to make your decision yourself, have the information to be able to make an informed decision is really important. And we do have a responsibility to make sure everybody gets information and advice. And then the final point is actually it is a commendable team. We have a really good setup in Nottinghamshire County Council. Gemma and her team, and the fact that it's integrated between health and social care is fantastic. It's not what happens everywhere. So I do commend the team for the work that they do, really. Thank you.
Yeah, please.
And just like I said, it's a really good discussion. I've not got anything to add, and obviously if we bring a future report about this, that'll be part of the work programming process in the summer. But it's just to remind members, we did have the annual safeguarding annual report at the last meeting, and members did agree that they would like a training session for all members on safeguarding, but due to changes of staffing in that team, we agreed it'd be kind of like late spring, kind of early summer. So that will be, but that is coming close now. So hopefully the next 2 or 3 months will be, well, before the summer, we should be able to get that training for you.
Thank you, Martin.
think we can offer it.
Yeah, we were going to offer it to all members because it's a vital part of,
Yeah, it's all councillors.
for all councillors to be aware of the safeguarding regimen. Okay. Right, thank you very much. Yeah, no, really good report, thank you. And some good questioning. Okay, and we've moved and seconded, so could we take a show of hands, please, for the report? Thank you very much. Right, okay. Moving on, agenda item number 5, which is page 35 on the agenda pack, and that's the progress update on the implementation of technology-enabled care strategy 24 to 27, 2024 to 2027. And could I invite you, Councillor Answer, to introduce the report, please?
Well, my colleagues will be once again giving you an in-depth report, but I will most certainly say that using technology in homes is absolutely fantastic. It's a way forward for care and for alerting people of problems. And I know a lot of you have been looking at the equipment upstairs in the room before the meeting and seeing, the equipment that's out there that we are using, because that's the key, we are using it. This is not new stuff, we're using it. But I want to make sure whatever comes on the market that's going to help us look after people better, that we take that on board. So with that, I'm going to ask our colleagues to engage. Thank you.
Thank you. It's me again. Okay, so we have done a lot of learning about technology-enabled care for 15 plus years, something like that, Mark.
20.
Yeah. And I think we've gone through the stages of learning how to use the right equipment. New equipment comes through all the time, but learning how to make sure that we are supporting people in the right ways with technology, understanding and respecting people's wishes, and becoming much more sophisticated about having an infrastructure to be able to do that really well. So after all of that learning, we then created our technology-enabled care strategy in March 2024. And what we do is bring through an annual update for you to see and hear in terms of how well we are doing against those ambitions. I'm going to start with 2 quotes. I had got a presentation and I know it wasn't possible to show it today, but I think this just brings home how important it is. The first one, the equipment for mum was life-changing and the cost of the service is next to nothing to have something that changes people's lives for the better. And then the second person is a carer, and it made caring for mum possible. I wouldn't have been able to do it without the technology. So this is the day-to-day things in your home that can really help to either keep you safe or keep you in the right place. So our strategy was set up after a lot of learning. We have Mark Douglas, which I'm really pleased to be able to join us today. And Mark ran a session to demonstrate some of that kit. I think quite a few people have been involved in that this morning. But we created that strategy on 9 themes or 9 ambitions. Firstly, to achieve a cultural shift in the use of technology. So making sure that people started to understand that it's out there. So things like this morning, just promoting the use and seeing what's possible is really important. But really important for our operational teams as well. So part of their conversations with people can be to talk about what you've already got in your home, what else you might have that can help you. Is all part of that good advice and guidance that people can have, even if you might not then need to progress with us as a council formally, self-funders, etc., starting to give that information. But then supporting the workforce to have the confidence to refer people to have technology in their homes, and also to get ahead of formal assessments to where we can now put tech into people's homes to monitor their daily living. So that there was another lovely story in the slides that talks about which we see all the time, a family that was really worried. Again, it was mum. They thought that there'd been reports that mum was leaving the house at night. Mum had got early dementia. She was leaving the house at night and that wasn't safe. And they were really worried and she probably needed to go into a care home. So we're able to then go in and put technology into the home that doesn't film people all the time, but actually alerts where mum is. Is she going into the kitchen regularly, suggesting that she is making food, having a drink, going to the bathroom regularly, sensors on the door to see is mum going in and out at night. And actually the tech showed she wasn't leaving the house at night. It was okay. It was clearly somebody else in the area. So it was okay. And that was understood. And I think in that particular scenario, because mum didn't want to go into a care home, mum wanted to stay at home. So mum was then supported to stay at home, but also what the tech had shown into that assessment was that mum was struggling to wash and dress. So it meant that then as part of that assessment and the social worker having that conversation, we could get some early morning support to help mum get out of bed, dressed and washed, and then she could happily be at home, etc., and not need to go into residential care. We've also had people that have had tech in their homes that they thought they needed to go into residential care, and after having the tech have said, I feel so much more confident now. I can't believe I was even considering going into a care home. I don't want to do that now. So those stories of difference have been so important. So achieving that cultural shift is ambition 1. Ambition 2, building on the current tech offer. So we have contracts that allow us to access a whole range of tech-enabled care and new products that are coming in. Transforming overnight and one-to-one care. We've got some really lovely examples where we have seen that people had a lot of nighttime staffing that were going in and checking at night time, which can be really intrusive. Most of us wouldn't want someone coming in our bedroom at night time to check on us, when actually technology can do that job, and technology can alert that you can have somebody nearby if needed that can then come in. And so we've got some lovely examples of where we've been able to swap that out. We have an ambition. It's also cheaper, which is good in terms of best value. We want to do more of that, and part of the plans between Emma and Emma's teams and my teams over this next year is to reach out and work with more providers to look if we can do more of that to support people and maximise their independence more. But also I think there's a future where there's potential in care homes, for example. We've got, again, ideas coming from care homes to say there's tech that can show with thermal imaging, so it's protecting the dignity of people, but can show when someone's had a fall, if they hit their head or not. That's so important that we don't send people to sit in A&E with dementia, for example, for long periods of time when they don't need to go. So, and also, again, to be explored, could technology do some of the checking in those early hours of the morning when staff are going in and out of bedrooms? Because what we do know is when it gets to about 4 or 5 o'clock in the morning, it would wake most of us up having someone coming in, and then that affects how you feel in the day if your sleep's been disrupted. So there's a lot of potential for us to explore with tech. Ambition 4, tech data to prevent a crisis and inform reviews. I've talked about that. Ambition 5, bring your own device, so we can actually have a look at what you've already got in the home and maximising the use of that. We've all got so much technology in our home that I bet we don't all use to the maximum unless you're a very technology focused person. So we can maximise what's there as well. Ambition 5, addressing digital exclusion needs. So where there are people that haven't had broadband, haven't got anything in their home, there's so many brilliant ways, and Mark can talk far and wide about examples of working with people and introducing some really nice simple text that's been quite life-changing, has connected them to people or interests, and just been really good. Ambition 7, evaluate our own infrastructure for being able to deliver hybrid, what we call hybrid care, which might be partly staffing and partly tech. So that's been important for us, but also we've got, as we saw in the last session, a community of practice with our external providers that is about digital innovation. So sharing again that hybrid care delivery between tech and staff. We're seeing some really exciting things in care homes. Ambition 8, transition from analogue to digital telecare. There was a big switch changeover nationally, wasn't there, Mark? And
Yeah, to 31st of January 2027, everything is going digital, basically with the phone network.
Yep, and we something like it's in the slides, 99.9% of the way there. I think we found 4 people that had not got broadband, and we're supporting them, but we are well ahead of that time scale, which is really good. And then ambition 9 is to improve our partnership working. So we're having lots of conversations because our health family colleagues, health organisations also use lots of technology for monitoring diabetes, blood sugars, all sorts of things. We want to make sure that that is as joined up as it can be. So I think there's quite a journey to go on in terms of the joining up yet, and actually our ambition as a whole system, but the ambition is there. We need to develop it. So that gives you a sense of our strategy and how it was set up. We are really quite far forwards in terms of reach when we compare to other local authorities. Based on the not very scientific information, but just talking, I certainly think we're in the upper quartile nationally of being ambitious about technology and sharing what we do. So we know that there's over 70% of people receiving support to stay at home have some sort of technology as part of their care and support, compared to 46% at this time last year. Actually, that's got the wrong year on it on my slide, hasn't it? 2 years ago. Compared to 2 years ago. So that is an incredible amount of reach. 70% of people at home having some sort of tech is really good. Over 500 people have had tech support that has prevented or delayed their entry to residential care, which is really good and responds to that question that came up earlier. 568 carers that were at high risk of a family breakdown with the sheer pressures of caring that people can feel have been supported with technology, and has massively reduced anxiety and stress. Over almost 1,180 carers have been supported with tech at all risk levels. We've had over 600 hospital discharges supported with technology, nearly 2,500 referrals for tech received from our operational teams, which we've just seen the increase, the trajectory go like this over the last 2 years, which is showing confidence, knowledge, it's working, which is really good. And Mark's team go out and do a lot of training and support. We switched to a new tech service delivery partner last year to give us access to a wider range of tech solutions. We've created guides to help people, to enable people to use their own digital advisors, and that is going to be part of our community directory as well, part of all that good early advice and guidance. And we've got lots of examples of things like tech being used to identify people at high risk of falls, anxiety, loneliness, and unmet personal care needs. So we can do so many things. I'm just going to flick through. I think there's another really nice example. So an example of somebody that is living in a supported housing scheme that needed assistance when showering. In the past, it was really sad actually, had to come out of the shower to get someone to then, when she was at the right point, to then get someone to come and help with that personal care. Now we have a simple waterproof call button that you can stay in the shower and press it when you're ready for the person to come. So in terms of dignity, things like that are so important. So hopefully we're showing you that we're doing really well. We have exceeded many of our targets. There is a target that we set for ourselves that we have struggled with, that is off track, which was to the amount of tech that we're putting out there to assess people's needs at an early stage with activity monitoring systems. And part of that has been about changing the system that we've been using, hasn't it, Mark? So now we're hoping that over the next year, now we've changed that system, we can get a lot more of that assessment tech out there and use it much more to help in the assessments that social workers are doing. So I'm going to pause there. Hopefully that's a good overview.
No, that was brilliant, Katie. Thank you. Anybody else? So,
Yeah, if I could say that from looking at assessments, particularly around Mansfield where I am, and very close, they've got a poppy fields, and we had 6 beds there for doing an assessment for that person, and they used to come out of the home and go into these homes to be assessed. It's finished. Those people having their assessments at home. You know, it's exactly what we want them to do. So those 6 rooms that they use for the assessments are now used for people for care. And so we made really good value of those. But the important thing is that, you know, they're now assessed at home. It doesn't matter whether they've got a little buzzer on the kettle to see whether they use the kettle or what have you. It means we know, and we can help and support, and we know what they really want from top to bottom without somebody sat with them. It's just absolutely brilliant technology, and I can tell you, I'm all for it.
no, absolutely. Okay, anything else? Okay, in that case, sorry, we'll move into questions in a moment, Councillor Vernon. I'm chomping at the bit. No, we're going to move the recommendations, and could I have a seconder, please?
I'll second that for you.
Thank you very much. And okay, going to open the floor for debate. Councillor Vernon.
Yeah, chomping at the bit, sorry. Probably not this section, but to me it is. Canines. So we're in the high-tech section, so I thought I'd mention the dogs. I've trained a few therapy dogs and assistance dogs in the past, but I don't see it anywhere here. So do we not use them?
I can come in there. We don't provide or commission therapy dogs for people drawing on care and support, although we do have people that we are working with who do have therapy dogs or other animals. That's usually done through voluntary sector organisations. So it's something that we haven't really looked at, but there's always interesting new ideas to explore. So yeah, happy to have a conversation about your experience outside of this.
Yeah, sorry to jump in on the tech.
Yeah, thank you.
Councillor Rich.
Thank you, Chair. So look at page 39. What is a specific plan to ensure the remaining of telecare customers without mobile signal or broadband access transition to for a digital signal before January 2027 switchover? Thank you.
I'll be honest with you, it's a challenge because we obviously we need to look at how we can get connectivity for those people. So the ways that we can connect are basically through mobile telephone networks, potentially through Wi-Fi, and those are probably about your only 2 options really. So unfortunately, we do have areas in the county where they're not spots where we don't get very reliable mobile signal. There is wider work going on in the authority around accurately mapping where we've got not spots, because one of the problems you have is if you use the mobile phone providers like O2 or EE, if you go online, you can check how strong a signal is, but it's all based on algorithms. And I'm not going to say it's make-believe, but there's an element of guesswork in there. So the council has already done some work to map mobile connectivity using dustbin lorries, and have had special equipment attached to them to record what the mobile signal is in certain areas. So as an authority, potentially we can work with some of the mobile network providers to say, look, we've got signal strength issues in this part of the county. It's Kimberley, for example, that seem to be particularly badly affected. Obviously, a lot of their decision making is commercial, but there may be opportunities for us to improve coverage in some areas, which then enables us to provide tech equipment to connect into it. In terms of broadband, then it's just a case really of working with, if we can't get mobile connectivity and we need to use broadband, it'd be a case really of working with families and the individuals concerned to see whether we can get broadband connections in there. But the reality is that there possibly will be some people where we are going to struggle to get any type of connectivity, just because the infrastructure is not there.
What about a satellite signal, like satellite? You know, they go like with FreeSat sort of thing. They could use that, some sort of technology that will help for adults with that needs. I mean, that's a third option as a consideration.
Yeah, there's obviously satellite connectivity. I mean, often that's quite expensive. And again, you know, part of the problem we've got is that a lot of decisions are obviously commercial decisions for providers. So if you've got someone who lives in a farmhouse in the middle of nowhere, the reality is it's not going to be commercially viable. Obviously, satellite can get around that, but a lot of the satellite connectivity services are quite expensive. So for families to pay for that is going to be quite a challenge, I'm afraid.
Thank you. I think I've got Councillor Girling first. Yeah.
Yeah, thanks, Jim. I'm talking about page 36, paragraph 5 and 6, if I may. I think the fact that we've got 85,000 calls doesn't necessarily mean that the care is getting to where it needs to be. Do we know out of those 85,000 calls, because you could get one person phoning up a lot of times, you know, so what's the sort of the spread really, if you think about how many people have got tech in terms of that, you know, wanting to do that sort of thing. It's interesting to see what things that they call up for, but, you know, 85,000 calls doesn't really give the right picture or give a full picture. And then just on paragraph 6, if I may, I'm just curious why you haven't set targets for the care supported with tech or risk levels, and the one below that, discharges supported with tech. You've not set yourself targets 25, 26. We're in 26 now. I just wondered why.
Yeah, okay. So first question was around the calls that go into the monitoring centre. You're quite right to delve deeper into that. Quite a significant proportion of calls are arguably false alarms. It's sometimes a bit difficult to differentiate between false alarms and an anxiety-related call. We do monitor high volume callers, and certainly every month there's typically sort of 10 to 20 people who are high volume callers. So last month, I'm racking my brain off the top of my head because I haven't got the figures in front of me, but I think we had one person who'd made some in the region of about 300 calls just as one individual. That person is known to us. We talk to them on a regular basis. We try to do things to reduce the calls, but the reality is that the issue for that particular individual is anxiety. It's loneliness, it's anxiety. So the monitoring centre, whilst in one sense or so we might say, well, that's a false call, the reality is that the monitoring centre is to some extent providing some reassurance and helping to address that person's loneliness. But we, you know, if we have everyone making that level of calls, it would obviously become unsustainable. So we do try to work with the person to look to see, can we make changes to their care package? Can we ask them to take a little bit more personal responsibility for using the system appropriately? And we just try to manage it through that process. I'll be honest with you, quite often, most people who are fit into that category, it tends to go a bit like that. So we intervene, the calls will come down, and then a couple of months later, they come back up again. It's a bit of a roller coaster, but we don't ignore it. We try to work with the information that's there. I've forgotten the second question.
About the targets.
About the targets. Yeah. So there are some targets in the strategy related to some of these areas. So in terms of carers, we did set a target to increase the number of what happens is when we get referrals through, we ask staff to risk assess the likelihood of the caring relationship breaking down. So they have different categories. So we did set a target to increase the number of carers that we support who we assess are at a high risk of carer breakdown, either immediately or within the next 3 months. And the target was to increase that by 20%, which is where that 442 target is. So we're exceeding that, because so far this year, between April and the end of January, we're already at 568. The 1,179 figure, you're quite right, we didn't set an overall target for the number of carers that we supported. With hindsight, perhaps that was an error, but it is something that we track, and we can very easily look at our data to see whether that's improved compared to previous few years. We have got that data. It's just we didn't set a particular target for that. We were focusing on the high stress carers where there was a risk of that relationship breaking down. And obviously, if that happens, that means quite often that those people are then going to be knocking at the door of social care to ask for formal care services to be put in place.
And if it's okay, just to add to that, thank you. In any strategy, it's hard to drive everything at the same time. So I think we tried to be ambitious within that strategy and set some targets in what felt like priority areas. There's also some learning, which has been really good, and where we've needed to pause and change the model, change the system and the way that we've been doing things. But actually, some of the ambition for next year is to continue and build on the successes that we've seen. But next year, we really do want to get into some of the areas that are about night staffing, and could we use technology more rather than night staff, as we've described? That feels a really big area for us. There was another one that was really important for next year, which has gone out of my head. But basically, now that we've achieved success in some areas, to maintain those and then to bring forward some of the others. And we have a tech working group in-house where we'll start to look at some of those kind of where we want to try and get to next. And we've been working some of that up, haven't we, Emma, in terms of how many providers we think we could work with and look at night staff, etc. I think also over the next year, we probably want to start looking at our tech strategy, but also the tech ambitions for our health partners in our health and care system, and begin to work towards the end of this strategy and what a joint strategy might look like beyond that.
Can I just add to that though? I mean, I don't think I'd encourage you to set targets for hospital discharge. I mean, when our experience shows that when we used to do it with equipment, if you say to somebody at the point of discharge from hospital, do you want a piece of equipment? They're likely to say yes. They're likely not to use it, and because they've not had any experience how to use it. And then they're likely to have it just sitting at home, not doing anything. Our experience shows it's better that most people who need ongoing support will go through the managing independent service or will get some form of reablement. Actually, at that point, having conversations about what tech can help you with and be less intrusive is the better time to do it than actually on discharge from hospital.
We've got follow-up, yeah.
I get what you're saying about going for the high risk ones first and everything. I sort of disagree in terms of setting targets, because targets gives a focus, you know, and you should always have an ambition to make sure that tech is out there. And if you don't set yourself a target, then it's, you know, it's like getting on a plane and not knowing where you're going, isn't it? So I would encourage that, even though you don't think it's the right thing to do. And then my only question in terms of the paragraph 5, where you said about the guy that did 300 calls, and a lot of it was because of anxiety and loneliness. I take it, and this is just for reassurance really, with somebody like that, then you'll try and get some sort of you know, age concern in and all that sort of thing to try and support that, which would imagine then would bring the calls down quite severely as well. But I can see you nodding. No need to answer that then, but you know, it's very important that we do get people into that, because that's where the health goes down if they're feeling lonely. Thank you.
Good. I just wanted to add to that. I mean, that you know, is referenced in the report, but that data, that information is incredibly valuable. You know, in previous years, we've not really used that data to the best of our abilities. I don't think. So we are picking up people individually. We are picking up on the high volume callers. One of the changes that's happened with our new contract provider is that they record the nature of the calls in a much more straightforward way. So it enables us to very quickly see, for example, people that have genuinely had a fall. Previously, we were being advised that somebody effectively may have had a fall, but it hadn't actually been confirmed, or that somebody was definitely saying, exhibiting behaviours that suggested they were lonely or anxious. So since the change of contract provider, we now get that information in a much more accessible format, and we're routinely now every month looking at those people and looking to see what we can do in terms of social care changes or indeed support in the community to address that. I mean, to give you an example, one of our high volume callers a few months ago, one of our social care teams got involved. That was a loneliness, anxiety situation, and they were just put in touch with a local community group, and they're now attending regular sessions with a local community group to address that loneliness and anxiety.
Councillor Gowland.
Thank you. I think my question kind of follows on in a way, or is linked to this. So, as I've said to a few people today, my neighbour has had one of these things that you will talk back to her and give her some feedback. I'm not sure the exact situation, but she really didn't like the talking back, and it went. So, but my question really is linked to that. What sort of response can be provided? Obviously some general reassurance. One of the examples you gave was incontinence. So if somebody rings or somehow calls to say they've had an incontinence issue, is there anybody who can come out to help them? Is there a sort of flying squad behind this?
Yeah, I can do that. And apologies because there's so many people upstairs. I didn't answer your question around the unit talking and that being distressing for the individual concerned. With some versions of that equipment, and actually the one that you saw upstairs, we can actually disable those reassurance messages. So if we have got someone who gets distressed by a white box that's trying to talk to them, we can actually disable that so that doesn't happen. So. And then your second question was around the response to those services. So the County Council does have a contract with a domiciliary care provider to provide a response service specifically for that. So, which I will say actually is relatively unusual. Quite often response services for this kind of equipment is provided by organisations that are not registered to provide domiciliary care, so they go out but they can't get involved with things like incontinence management because that's seen as a care task. So we have a 24-hour response service. So the monitoring centre, when they get the call, they will triage and assess the call. If they think it's appropriate, they will then contact those responders, and they're contracted to get on site within 45 minutes in 90% of cases, which is a kind of an industry standard target that's generally accepted in the sector. Interestingly, about 30% of the calls that they attend are continence related. So it's either helping people, thankfully some people manage to hold on, so then they manage to get out quickly enough to assist the person to use a toilet or commode. It might be they have lifting and handling issues, but if an accident has happened, then they will assist them to get cleaned up and change bedding and things. Okay.
I have no further questions. I'm just so happy to hear that. I mean, this ultimately leads to much better care and more timely care. It's fantastic.
Councillor Rich.
Thank you, Chair. I'm looking at page 41, section 14. Can you provide more details on the financial impact of the tech strategy, specifically how the 2.67 million in voided care cost pressures for the first 10 months of 2025 to 2026 was calculated using the, I'm going to say it, but the ADAS model? Thank you.
Yeah, I'll do a quick one and then hand to you, Mark. It was really important to us that we, as we implemented this strategy, we were also we have a best value duty, looking at how we spend the financial envelope that we've got. So it was important to us to look at the preventative impact financially and the cost reduction financially. And most of the tech work that we've done has been about early support, thinking tech first, thinking reablement, thinking maximising independence first. What we've done as we've been putting the tech in, is talking with our operational teams about if the tech wasn't here, what would we be doing? So that scenario where the family thought mum was leaving the house at night time, obviously more information would still have been collected, but we would look at the likelihood of somebody going to residential care, or the likelihood of putting more staffing in, for example. So that's how we get to some of these costs. Person by person, we look at, if we didn't have this tech, what would we do in this situation? So it's theoretical, but I think what we can show is actually it's really effective financially in terms of preventing spending on things that weren't needed and weren't in line with what the person wanted either. We have got some examples like taking the staff out at night and having tech in that actually takes money out. So that is an actual cost reduction. But it's important, part of our work is to make sure that we are driving best value using resources in the right way. So that's why we put some of that in.
Yeah, can I just add to that, because you'll see savings figures out there for all, particularly from manufacturers and suppliers. You know, all the wonderful things they do and huge headline figures that say 5 million, 8 million, etc., etc. As Katie said, there's obviously, if you're talking about preventing something that's going to happen in the future, there's an element of guesswork involved with that. I will be honest, but the method that we use in Nottinghamshire, it really is quite strict compared to what other local authorities do. So to give you an example in terms of, so we calculate if somebody doesn't go into a residential care home, there's obviously a saving associated with that. I've seen organisations and local authorities present that as a gross saving. So they basically say the residential care placement would have cost £1,000 a week, therefore we've saved £1,000 a week. We do not do that in Nottinghamshire. We say, okay, how much does it cost to keep that person at home? So we've got quite a sophisticated tracking system that if anyone is assessed as at a high and immediate risk of a residential care admission, we track those people, and if we're providing services to keep them in their own homes, we subtract that from the cost of the residential care placement. So if we've got a care package that costs £300 with home care, that's going to come off your £1,000. We also deduct the loss of income, because if people go into residential care homes, because we sell people's houses and we tend to get more income from people in residential care, that we're obviously losing that income if that person is not going into residential care. So we take that off as well, and we take off the cost of the obviously providing the tech equipment and services. So we've worked with our finance colleagues on that methodology so that they're happy with it, and it is seen. I think it might be mentioned in the report. We had an external audit by some consultants a few years ago who described our method as being an exemplar nationally, and elements of our method have also been taken by the Telecare Services Association, which is a national industry body, as an example of good practice. But to be fair, our methods that was too complex for them to kind of recommend elsewhere, because there really is quite a high level of sophistication with some of the tracking there, because it's in real time. It's not based on actuals. We look at the actual actual cost of keeping those people at home when we're working out the savings figures. So it's about as robust as it can be, given that you're effectively looking into a bit of a crystal ball as to what may have happened.
Okay, so I have a question really. First of all, the demonstration upstairs was really good, really useful certainly for myself, and I'm sure I can speak for all members here. You know, it brings it all to life, and obviously we're not now just talking about a concept. But in terms of sort of future development, what kind of new technology is coming down the line in the next few years? And with all that, and I can see the enthusiasm, but what risks do we see with technology-enabled care? Because we obviously talk about the enthusiasm, and you know, you can easily become blinded by the hype, let's say, but you know, there's always a shadow side. So, you know, what from the council's perspective, what are the risks?
Okay, I'll start. I think the biggest risk actually is what you're saying is don't be complacent and don't think that's lovely and shiny and new and therefore it's the answer to everything. You know, people have to be at the roots of it. And I think one of the obvious risks and concerns that probably all of us would share is that technology is used in a way that it replaces human interactions and human contact. And that's tricky. There's a dilemma because there's a balance. Obviously, we've got to work to budgets there. But I think, you know, the moment we start, there's a very simple thing actually in the strategy that says, you know, we have this concept of tech first, which is what we've been trying to embed with our staff, and that's that it's cost effective for people, but it maintains or improves outcomes for people. And if we start deviating from that, we start having worse outcomes for people. If we start deteriorating the quality of their life as a result of using tech, then my view would be we've gone wrong. So it's quite a small bit in the strategy, but for me, that's quite a fundamental principle that we have to stick to if we're using it. Yes, it might save us money, and that's obviously really important, but we need to only use it where it's maintaining or improving people's lives, improving outcomes for them. In terms of technologies, what's down the line? I mean, data is probably the big area. You know, these systems, as we've said, are collecting huge volumes of information and data, and historically organisations have used it primarily to provide an immediate reactive response. What we don't do is analyse that data and begin to use it as a predictive tool. So, for example, somebody might have an automatic fall detector. Some of you saw those upstairs. It will pick up that someone's had a fall, which is great, and we can provide an intervention. But actually, if we can see from their data and using wearable technologies, for example, that somebody's activity levels have started to decline, or there's some equipment that's coming on the market now which will do gait analysis, then that we're getting into the realms of being able to potentially predict that person A is going to have a fall within the next 6 weeks or 2 months. So the challenge for local authorities in that scenario is what is the response to that, and fundamentally that is a really big challenge because you're beginning to change the way that care is provided. How do you respond to that information is the key question.
I agree. I think the predictive capabilities that will be coming through are really interesting. There'll be some stuff that is absolutely brilliant. There'll be a shadow side to that. We're going to have to think really carefully. But actually, I think in the interim, and what will help as that is coming through, is the position that we get to where actually our wraparound infrastructure technology improves. So we're not just looking at we've got the call buttons coming into one place. We've got assessment technology coming into one place. We will end up in a situation in the next few years where we've got wraparound infrastructure that pulls the data from all of those places and organises it for operational staff. So on a Tuesday morning when they log on, they can see, I've got a couple of alerts here about 2 people that had an issue last night. And there's a pattern that's being shown because I've got data from a range of things that is not just from the technology, but from intelligence coming from other places that can help people to not only save them time in having to go in and out of different systems, but have more live data, and it will organise that for them. And I think that is going to be a really good thing for operational teams. But I do agree with what Mark said about the predictive AI that will be coming through is going to be interesting.
Just to add a few things to that. I mean, we all know that criminals and fraudsters will move to where things move to. So we know that digital is a huge area in which people will manipulate that. I think thinking about how we talked about connectivity and making sure that it's secure, but actually making sure in the future, a social worker will be assessing whether people have updated their equipment. So actually it's the latest and safest that it can be. Those are things that we're not necessarily do now, but we will have to do it in the future, really. Cost of equipment, cost of things is usually one where people steal things because they think they when that thing comes lower in price, they tend to not be things that people want to then steal anymore. I think the data is really interesting. This is a really interesting area because Katie and I were in a meeting with health colleagues where we were looking at unidentified information, but people who are likely to have a heart attack in the next 2 years. People go, well, why would I be interested in that? But I was saying, actually, what I really want to know is if they're a person who's a carer who's looking after somebody and they're likely to have a heart attack, are they a single carer? Are they going to have different needs themselves? Is that something that we're going to be able to predict? And are those people who they're looking after have independent skills? We can get in there early and make sure that we do some of that before. That's the proactiveness that we want to use intelligence with, really.
Yeah, no, totally. And, safeguarding around data itself, because, when you've got people's health informatics sat on a server somewhere, wherever, is that data ever likely to be either hacked or potential, even sold? We hear of this all the time. And your point about predictive health information, particularly for, say, younger people who, for whatever reason, are in the system, and that information could then be used against them at a future point, say, for example, buying insurance or something like that. So I see a whole host of challenges around AI, and I was sat on the overview committee the other day, and one of the points there was around AI and the use of AI in this council. So, yeah, I definitely see great opportunities, but a lot of challenges as well. So, yeah, thank you. Any further questions? I think we're okay. Okay. Sorry, Councillor Answer.
Yeah, if I could say that, technologies, we all know how fast technology is moving. We've got to update our phone. And the additional items that you've got on your phone that you didn't have last year, is unbelievable. So technology is going to move on. It's going to move on fast. I would think that we'd have an element of security around that, without a doubt. And I think we'd have to have a risk assessments on everything that we use as well. But for example, I went to one nursing home where they've got a device on the room, and it tells them if somebody stops breathing. Nobody's there outside of them, but if their breathing patterns change in the night, it alerts people. And that, again, is, fantastic stuff for the nursing homes or for anywhere where they've got people in care. So technology is moving on, but we do have to be careful. We all know how many emails we get and different things that we get from spam and stuff. So we do have to be careful. So we have to have our own firewalls and our own safety cares there. So, yeah, I look forward to even more stuff coming forward and making it even better, not just for the council, but for the residents.
I couldn't agree more, Councillor Answer. Thank you. Okay. In that case, Martin hasn't got anything to add, so the recommendations have been moved. So can we take a show of hands, please? Lovely. Thank you very much. Okay, moving on to agenda item number 6, which is the adult social care performance risk and financial position for Q3 25-26, which is page 45 of the agenda pack. And Councillor Answer, would you like to introduce the report?
Yes.
Okay, so I'm going to take you through the first parts of the report, and Mark's left the room, but I was immediately thinking K9, Doctor Who, we're missing a trick in terms of support with tech support. As Councillor Answer has taken us through the purpose of the report, this is reviewing our progress against our local account priorities, which have come out of our big conversation, which is our strategy and our plan for the year. So I'm going to take us through to the Making It Real themes, the first one of which is Wellbeing in Independence. And this is our performance at the end of the quarter 3, which is to the end of December. We'll start with long-term care. And this is long-term care admissions and also number of people in long-term care, residential or nursing, and split into older adults or over 65 population, shall we say, and then working age adults. Now, we are making good progress in this area of our work, as we've talked about already, about that increased amount of supported living accommodation for working age adults in order to move people from residential or prevent additions into residential care in the first place. However, for both of these targets around number of adults in residential care and new admissions, we are over where we would want to be this time of this year. So in terms of we're ragging as amber for our working age adults, so that's the 18 to 16-year-olds. We've set a target of 75 new admissions this year. At the end of December, we were at 59, so we're tracking at that point, but that's to give still amber because we're wanting to ensure that any younger adults who don't need to go into residential care don't go into residential care this quarter and then the next year moving forward. In terms of our population, we, in terms of working adults in residential care, it's on a really clear programme to step people out into supported living where we can, and then for people in supported living accommodation or supported accommodation to be able to then to move them into general needs housing. But that does depend on us having the housing stock available for people to move into. In terms of older adults, we are above where we would want to be. So our actual target of new admissions last year was 1,091 people moved in, and we were at 686 in December, with a target this year of 765. Now that's we're just moving into winter pressures as we come into November, December, so we do see our admissions increase at that time, and we are keeping close eye on that. Have been over the last few months into spring. And the same in terms of number of older adults in residential care. We're still above where we would like to be. We are working in terms of repeating the work we've been doing with working age adults to think about extra care accommodation, so preventing the need for people to move into residential care when they're over 65, and also where we can, if people are in residential care and we can support their needs more effectively in their own home with their own front door, we would support them out of residential care. In some situations, we've managed to do that successfully. So we've been undertaking a needs assessment of our extra care capacity, what we've got, what we think we need. We are we have an ageing demographic in Nottinghamshire, and we have a projected number of older adults is increasing, particularly over 85 population. So that does mean we expect to see more demand for older adult support, but we want to do that for people at home, in their own homes, or as close to that as we possibly can do. So work is taking place to improve on that. So I'm going to keep going through and obviously take questions afterwards. We've talked a bit about the tech and actually how that can help prevent some admissions into residential care for working age adults and for older adults. And again, that work to improve in terms of the more the tech becomes available, we can hopefully support people to be at home for longer or not need to go in the first place. So I'll take us through to our waiting times. So this has been a key area, again, priority for us in terms of waiting times for assessment for our adults. And this has been a key priority over the last 6 months. So we had seen our waiting times increase. I'll take you to the graph, which is in purple and green, through the early late spring, early summer, and a high number of people waiting during the summer. We've now seen through some targeted interventions that number of people waiting and the amount of time they're waiting reducing, and we continue on that in terms of that trajectory. The key things to note about waiting times are that we see people who are urgent as quickly as possible, and that can be on the same day. So all of our new referrals are triaged and risk rated in terms of the urgency of the request for support or assessment. Those lists for, in terms of waiting lists, are reviewed on a weekly basis by our managers and then are reviewed by me on a fortnightly basis. We've been working out different ways of getting to people quicker, and we've also been undertaking a bit of a data cleansing exercise on our systems, which were showing that some people were waiting and actually weren't. So we've also been doing some work to bring those numbers down in that respect. So from two areas, but we've certainly seen some improvements compared to this time last year in terms of maximum times in waiting and our averages in terms of waiting times. and it remains a key priority. We don't want people to be waiting more than 28 days, so that's our target. We'll move on to the Making It Real theme 2, which is information advice. We've got an update in here about the implementation of our new county-wide You're Nots directory, which is amalgamating the advice and guidance directories that we and the city have. And we've combined the Left Lion or Ask Lion approach from the city and our Nots Help Yourself into a much more interactive and user-friendly directory for the county. So that's something that's being tested and will be coming out early 26. So I think we're just about there, aren't we? Imminently, any day now. So hopefully that will help our residents to find the information they need much more quickly. And it also helps our staff also when they're looking to see what's around for people that they're working with. We've also, in terms of a bit of information and following on from the tech and AI conversation, we've been rolling out a new tool for our social care staff called Magic Notes, which is a dictation device. This means that when they're undertaking an assessment or a review conversation with a person and or their family, with their permission, we can record the conversation, which then draws out the key themes and so helps the worker to have a conversation without having to record an assessment at the same time in terms of writing. So the key things about that is we're seeing much more clearly represented the person's voice coming through in our assessments and reviews. We can actually ask for quotes for what the person has said about what their wishes, what their goals and aspirations are, or what they need help with. It's also saving our staff time. So rather than spending so much time in front of the computer writing up their visits and their assessments, they're actually spending more of that time with people, with carers and with families, which has been a really important shift for us in terms of providing a much better quality of service. Again, so it's sense checked. It's a tool for our staff to use, and at the end of the day, we're finding a quality of assessments and support plans is improving, but there's always a human element to checking the information, to fact checking it, and making sure that it's correct. I'll take us through to Making It Real number 3, which is active and supportive communities, and a really positive story to tell here in terms of us supporting adults into employment, education, training and volunteering. So by December, we had 778 working age adults who've been supported into those opportunities against a target of 825. So that's 90% of the target had been achieved by December. And these are people who otherwise would not be involved in volunteering, training, work. And actually, for some of these people, we've looked at where they've been having statutory, maybe day opportunity services, but actually thought, you can aspire to so much more. How can we support you to think about doing things differently? And actually that route for some people into paid employment, which has been really fantastic news for them and for all of us as well. A key element of this is Brook Farm, just down the road, where we have vocational pathways in terms of training. And they've currently got their highest ever number of employment hub trainees at the service, which was 28 by November, with expecting to have 30 by the end of the year. And this is specific targeted work around achieving employment goals, so promoting independence, but also understanding the world of work and also gaining work skills. So again, a really important part of the service that we provide and some really good outcomes for those individuals. A key thing to note about that as well, thinking about our younger people coming through to adult services, is Brook Farms, some representatives from Brook Farm went to one of our Preparing for Adulthood events to speak to young people, then their families and schools and others, to talk about work, volunteering, how important that is, to really think about us raising aspirations for our young people with disabilities, and really thinking about how can we to follow on from college for some of those people, then to think about Brook Farm or other alternatives in terms of employment. So really important that we're aspiring for better for your younger adults. I'll take us through to flexible and integrated care and support, and first on to people's annual review conversations, which is an area of priority improvement for us. So in terms of our percentage of people who've received a formal review in the last 12 months of their care and support, we benchmark higher for regional and national. However, we are benchmarking low. We are lower in terms of our performance where we would like to be. So our target is 100% in that everybody should have their care and support reviewed every year. We undertake a number of unplanned reviews when people's needs change. But in terms of that regular 12-month review cycle, at December we're at 60, just over 60%. Our we achieved 75% last year by the end of March, so we're keen to improve that reviewing activity. So one of the key things that we've done is ring fence some of our community staff to actually be undertaking those annual reviews with people. So that's their day job now. And also with the implementation of Magic Notes, we are seeing it's taking less time for staff to write up those review conversations on our systems, and they're actually able to get out and take those review conversations in person more quickly, so more time effective. So we'll obviously keep you informed of that progress over the next quarter and then into the new year. I'll take us on to direct payments. So we're significantly above average nationally for direct payments in Nottinghamshire. And that's for our younger adults and for our older adults. So we're RAG rating green in terms of our number of direct payments for working age adults. And we're just coming to national average. This was in the December figures, with still time to go until the end of March. We've seen a reduction in older adults receiving a direct payment, but that's been partly because for some older adults, particularly through COVID, we struggled with home care capacity. So we were using private agencies as a direct payment rather than a home care contract for some, but they were providing domiciliary care, but through a direct payment mechanism. As we've looked at our home care market has become much more sufficient in terms of coverage, some of those older adults and their families have decided that they don't want to worry about managing a direct payment and they'd rather we manage their support for them. And we're able to do that now because we've got the appropriate home care across the county for them. So whereas we'd like to see all those who would like to have a direct payment, because it can improve their sort of control and their choice about how their support is provided, we would really want to encourage, rather than using an agency for that people use personal assistants, and then they can have a much more flexible model of support around their needs, rather than being fitted in with the times of other people on a run, necessarily perhaps for home care. So it's an area for us to continue to watch, and also to think more creatively about how we can use direct payments really to ensure that people have really good flexible support around their needs. Okay, so moving us on to Making It Real, theme 5. And this is about when things need to change, and particularly around our maximising independence service. So in terms of the Maximising Independence Service, who provide our enablement and re-ablement service for adults, and that can be young people coming through from children's services into adults in terms of promoting their independence. A significant number of people supported by the Maximising Independence Service are coming out of hospital, and that's stepping down after hospital discharge back home and being supported in that way. So in terms of, we are sort of on target to achieve those targets in terms of number of people who've had those re-ablement services. The area where we would just want to see a slight improvement is around the promoting independence work, which is enablement, so learning new skills. We have a set of staff called promoting independence workers who work with a person around the goals that they want to achieve. It might be how to budget, manage money, it might be how to cook for themselves and other areas. So that's something we'd like to see increase more. We're still on track to meet target, but it's amber rather than green in that area. I'll move us on to safeguarding, and this is again another really strong story of strong performance. So in terms of Q3, we were still consistently RAG rated green and above target actually for some areas in terms of our safeguarding activity. So in terms of, really importantly, the number of people who were asked what they wanted as a result of safeguarding, what we would term making safeguarding personal, was 85%. We set a target of 100% because everybody should be asked that, but in some instances it may not be possible to get their views directly, although we would use an advocate in that case, but perhaps where somebody doesn't want to engage with us and they can make that decision if they wish to, if they've got capacity, or sadly perhaps where sometimes people may pass away and we can't gather that information would be 2 reasons why we couldn't make that to be 100%. In terms of number of people who felt they were listened to and their outcomes achieved, that was 97% in end of December against a target of 95%. In terms of the outcome of a safeguarding intervention where risk has been reduced or removed, again, that's 93%, against a target of 91%, which just shows the effectiveness of those interventions. And in terms of those people who do lack capacity, ensuring that they are supported to give their views, or someone gives their views as a representative on their behalf, and that might be a family member, might be a friend, it may be an advocate. Again, we're at 85, nearly 86% of those people also. So really strong performance in there, and that's through our team at the multi-agency safeguarding hub, the MASH, based here, through to operational staff, and also in terms of Katie's area of service, in terms of the contracting team that we heard about earlier before. So really comprehensive approach to safeguarding and ensuring that people are safe or always safeguarded from abuse as much as possible. Also in terms of safeguarding, I'll take us through to deprivation of liberty safeguards. Again, we're RAG rating green against our targets here. So this is the number of people who lack capacity, living in residential and nursing care, who can't consent to where they reside to receive care and treatment, and so and are deprived of their liberty. They're not able to leave that service. So in terms of our number of assessments completed in year up to December around deprivation of liberty assessments, that was just under 70%. And then that rolling assessments, because once people are in, they also then need to be reviewed in terms of those renewing their circumstances at 75% of those. A little bit in terms of waiting times there, but again, it's an area of priority, and we get to people as quickly as we can in terms of these circumstances, and also risk rate in terms of how urgent, how severe, and the concerns noted in terms of how quickly we get to them. Taking us through to workforce. We've had some continued challenges during Q3 with high levels of sickness absence. The concern really for us, and something that we're working actively to overcome and to reduce and support, has been through stress, depression and anxiety as the highest reason why staff are off sick. In some ways, that's not surprising in terms of the sorts of work that they do. The emotional toll of that is quite considerable. But we are something that we're watching. We have a really good offer in terms of, for the workforce, in terms of talking therapies, counselling and other approaches. So encouraging our staff to engage with that as much as possible, and to think about the things within work that cause stress and anxiety. For example, some of the amount of work they spend in time in front of the computer, how we can alleviate some of those pressures also. So it's something we're keeping under close scrutiny. Our vacancy rates vary depending on sort of different areas of the service, but we've seen some really successful recruitment initiatives over this year, particularly for community care officers who are work alongside our social workers and occupational therapists. Really strong recruitment in that area, so that's been a real positive. The area of, that we've struggled to recruit is experienced social workers, and that's the national as well as regional issue, so not just for Nottinghamshire. And again, something we're trying to think differently and creatively about is how do we encourage people to come to us, come to Notts. So our offer in terms of our workforce offer, the support that we offer in terms of supervision for social workers, career progression and all of those sorts of things, we're thinking about what more can we do in those areas. I'll take us through to agency use. So when we do need to use agency staff, we do only where that is a real service need for that. And that might be where we've got levels of sickness or vacancy or cover for example, something like maternity leave or something like that. But we are we've had a real close eye on our agency spend and our number of agency staff, and have been reviewing that monthly and reducing that down to in terms of being really clear about the business need for agency staff, and think about how we can recruit into those posts if they are vacant, and actually what we're asking agency staff to do. So I'll take us through to vital signs and departmental risks. Do you want me to pass to Guy? Thank you.
Okay, thanks, Emma. Thanks for that. On the vital signs, that also the comment earlier, it's not very clear when it's in printed version like this, but actually it's a repeat of some of the things that are already in the things that Emma has talked. So it talks about the reviews, the assessments, the safeguarding in the same way as you described. The departmental risk register in here, I'll just pull out a few. It's worth saying that when we had the council's peer review, the adult social care risk register was held up as a good example, and actually was then used for wider departments to do one similar to us, really. They're pretty static, but there'll be ones that move over the coming months, really. So local government reform is pretty static at the moment because we're out to consultation through the government on which reform option will be taken for LGR. That will likely to make a decision in summer. That's when things will likely change, and then that risk will be reassessed on that basis. Likewise with the CQC, that's likely to be stood down after this month when we get the outcome of the assessment and that's published. And the sustainability of the services in adult social care, I think, is a good news story in terms of it's improving. and does link actually to the item around the finances. I think it's important that we link the performance, the risks and the finance together, really. If you think about the outturn position from last year, we were 20 million overspending. This quarter, we're reporting the 11.15 overspending. I can say that is likely to go up by the end of the year, but nowhere near to the extent of which it was at the end of last year. So things like we've been talking today around the tech, etc., are all things that are contributing to reducing that annual overspend, really, even though there are pressures and the cost of care continues to go up year on year. It's just a fact of life at the moment, really. I'll happy to take questions on that.
So, can I seek a seconder, please?
I'll second that for you.
Thank you very much. And I'm going to open the floor to debate. Councillor Cox.
Thank you, Chair. I've got a couple of questions, but obviously I'll one at a time. The ACS, which of the ACS performing well and where are they not looking so good, where we need to improve, please? Yeah, the active and sport communities, where are we performing well in that regard? You've got on active and sporting communities. Sorry, I've cut it down myself. I'm trying to keep it council-like.
Apologies, I could shout. I won't. So we've got, in terms of communities, in terms of, are you thinking about districts and boroughs and in terms of where people live and what's available? Is that sort of what you were thinking with that question? Yeah. So across the council footprint, we've got different communities with different strengths, I'll be honest. So we see some really good innovative provision and ideas in some areas that then we might scale up and share in others. Our district and borough colleagues do a huge amount of community development work, which is really welcome, and really thinking also about leisure and housing and those building blocks of health in terms of how do we support people to live good, healthy lives in terms of the work that we do with that. And a lot of that's in collaboration really with what we're doing in adult social care, what's happening in children's, and also what's happening in public health and our communities teams there. In terms of our, just trying to think of some examples, we've got some really innovative work happening up in the north in Bassetlaw, looking at circles of support and how do we think much more creatively about how we link in with community and voluntary sector to support people, particularly around isolation and loneliness. So the key example that we sort of talked about earlier with the man who was calling 300 times, I don't know if he's a Bassetlaw man, but we would certainly be wanting to link that person in with that sort of provision. And we're seeing that being really effective. We're also using from sort of thinking about how we become more present in our local communities from adult social care is actually how can we get our staff out? Where are they actually meeting people? Where are they visible? And how are they connecting with people? So using things like our libraries, some of our other buildings, leisure centres and others to see people, to undertake some of their assessments and their reviews as well. So that's really key. Just trying to think about an example. From the south, we've had some really good work joint with health around dementia and people caring for those living with dementia, which has seen some really good outcomes in terms of support. And in Mid-Knots, we've got some really excellent, actually, in terms of the Ashfield area, some really good community development with us, the District Council, with our health colleagues and the community voluntary sector, think about different ways to support people. A key element of that also is on integrated neighbourhood working. So in terms of neighbourhood health and well-being is actually thinking about what our teams need to be in their kind of locality footprints and who are they working with to support people and families better. So some really good examples of integrated neighbourhood teams, which are a virtual team made of social care, primary care, so GP, community health services, mental health, as and when needed, community voluntary sector, housing, all getting around together to talk about those people, those families that we're all working with, but have done so quite separately, and actually how can we have a much more integrated approach to supporting them. So that's a key piece of work that we're then building on, which is us doing that nationally, locally, but it's also a national agenda as well in terms of that shift from sort of acute hospitals into community health, and also us thinking how can we get out there and do things better. So I hope that's answered your question.
Yeah, thank you. Are we using the, sorry, I'm just, it's leaving on because it's opened up the thing. Are we using the sort of, you mentioned about the libraries and that for the community hubs to be sort of utilised. Are we using them efficiently? And same with doctor surgeries. I mean, my local surgery's got a large space of office space
Yes.
that could be utilised for these very type of hubs and these type of meetings. Are we utilising them as well as we can be?
I think we can do more, is the honest answer to that. And that's a conversation with us and our partners. But certainly that consideration about co-location and how do we have those professionals sitting in the same office talking about working with the same people is somewhere we'd really want to get to. In Ashfield and Mansfield, for older adults, we did have that model in terms of social workers based in health centres pre-COVID. We lost that office space during COVID, and we're keen, again, still to be getting back into those spaces. The virtual Teams, Zoom calls, things help in some of that, but actually there's something also about all sitting around with a cup of tea, actually having that chat, and some of the spontaneous conversations that come from that as well in terms of visits and coordinating joint visits more effectively. So I think there's more to go in terms of the libraries, in terms of other places. We've got Best Years Hub working in Newark and Sherwood, for example, some really good pop-up opportunities in the communities for our staff and others to get in, led by community voluntary sector, been brilliant. And often they're better at it than we are. So it's also about how do we support them to, to do that well as well. It's really important.
That's great, thank you. I mean, I think the only thing out closing that conversation down now is just the publication, that the publicity that we put out there that these events are taking place.
Absolutely.
Because I think one of the biggest issues I've certainly been sort of spoken to about is, well, we didn't know that was happening. We didn't know that was happening. And of course, if we can publicise that and even through us as councillors,
absolutely,
you tell us there's an event going on, we can publicise on our social media as well as what's out on the county lines as well as everything else like that. So I think that's great. Thank you.
No, thank you very much. And I think slightly back to the community directory, that will also help in terms of having much more interactive, up to date, ways of sharing that information. That's one way of doing it. Word of mouth and others is in actually social media is another key way. So absolutely, thank you.
Councillor Gerlin.
Yeah, so, thank you, Chairman. I'm on page 57, paragraphs 43 to 45, if that helps. I mean, overspend has increased since early in the year. Why are financial pressures worsening despite mitigation plans?
So I'll make a start and then I think I'll hand over to Guy. But I suppose speaking for our operational services and where our community care budget sits, which is the bulk of our spend, is the support that we provide to people. That's where most of our money goes. We've undertaken a number of mitigations, particularly thinking about the support we provide for people, how we make sure that's as proportionate as it needs to be, that we're not over-providing, and that where there are opportunities to do things differently and more innovatively, that we're embracing those opportunities. The tech would be one. Thinking about use of community voluntary sector organisations, how do we support people into work? All of those things are key, as well as improving people's sort of independence through the reablement service that we provide, for example. However, alongside that, we have a number of people in services where we would like to move them on, but we don't always have the next step provision for them or the right alternative. So one of those examples would be residential care for older people. We need more extra care accommodation. That's something Katie's teams are working on. It takes a while to arrange those services, to build those places. We need more supported living, brilliant work taking place. Again, it takes time to get those services up and running. Some of the other key things I think also just to note are the cost of care has increased in terms of how much we pay our providers for their support, particularly for those working age adults with complex needs around mental health, learning disability and autism. It's been a key area where we've seen increasing care costs. So we can mitigate in some areas, but we're still seeing costs increasing in others. So it's a continual attempt to balance in terms of honesty. But I'll hand on to Guy for some other key points on that area.
Thanks, Emma. I mean, I would say, look, this is a national problem. It's not a Nottinghamshire problem. Everybody's finding the cost of care increasing, and we do our best to try and keep within the budget. We are lower this year than we were last year, so that's going in the right direction. Remembering we are a demand-led service, so where assessments take place and we assess somebody as needing care, we are obliged to actually provide that care. What we do a lot of work in the background on is trying to make sure that that's good value for money. It's at the best price we can get it for, some of the alterations we've made recently is for us to have a brokerage service that will start doing the negotiations with providers around the cost of that care, so it's not left to lots of different social workers having to negotiate quite often at difficult times when they're trying to get somebody into a care package. So that means that we've got people specifically working with providers and creeping those costs down. It is still only a variance of 3.4%, and that's on the net budget. We did it by a gross budget, it'd be even lower than that. So it's actually not that much out of the budget, really. It's be less than 3% on the gross budget. Thank you.
Okay, any further questions? Okay. Deprivation of liberty safeguards. I note here this is section 34, page 54. I note that the RAG status is green, and the waiting list has fallen from 1,400 cases to just under 1,300. So you know, a decent drop, but it still seems very high. And obviously, if we're talking about deprivation of liberty, those safeguardings, in my mind, if you're depriving somebody of their liberty, that assessment should be done pretty much immediately, in my view. Could you talk us through why the backlog is high? Obviously, I've noted that it is coming down, and talk us through what the improved throughput, increased assessment activity, and strengthened triage processes actually is, and how that has contributed to this fall, and will we see the fall, the trend still going down, and what do we think is an acceptable backlog? Thank you.
I'm going to start with saying again, this is a national problem. It's not a Nottinghamshire problem. The deprivation of liberty safeguards is a very bureaucratic, complicated system which has been recognised by governments, successive governments. There is an alternative to be put in place that is going to overtake Goodall's assessment. Anybody who is deprived of their liberty, and it can be anything from 3 months to a year, have to be reviewed. And so on an annual basis, it doesn't just involve our staff, it also involves Section 12 doctors to be able to do and undertake those things. Currently, I'm concerned about how much money it costs us to do this. So we spend millions of pounds on having to do this, which is why nationally we've said this is not an affordable system for it to work properly. I mean, to give some assurance, most of these people are in settings where they are seen and regularly by people, either by the staff in the care homes where they are, either in a hospital, because they could be in a hospital with brain injuries, etc., or be in other settings where the care has been provided. So I think we've done really well, but at a cost for us to do that. And when we put that cost in there, it's taking it away from somewhere else. So I think we should be lobbying and encouraging us to get into the new system that is sitting on the shelf somewhere, waiting for us to be enacted to enable us to then move to a system that is proportionate and appropriate, really.
Councillor Gowland.
Sorry, I've been sort of sitting here not sure if this question really comes under this report, and I'm not really certain. If so, tell me. I've had a number of issues with residents having battles, honestly, with the county about charges to them and payments to them, and just a nightmare of paperwork that highly competent residents have managed to negotiate, and I feel there are probably other residents out there just completely lost. I just wonder, is this where I should be asking about it? I'm not quite sure if it's that section on payments, sorry.
I would start with saying income is a really important part of our budget, so I think it's right to ask it within the budget section. When I talked about the net budget and 3% and the gross, actually a lot of that gross income is because it's income from residents contributing to their care. So I think it's a fair question. I think it's a very complicated system to enable people to understand their care costs, and it's a range of people not contributing to care because they can't afford it, and we only charge people who can afford it. And then there's people who will pay partly towards their care and then fully fund their care. We have done a lot of work in the last year to enable letters to be much more appropriately worded, because actually I think there's some technical things beneath it that have to go to people, but actually the letter in front of it needs to be much simpler. And we've done a lot of work in the last year to enable that to be more understandable. I know that. I think there's still a way to go though. But I do think the both the Mosaic system, which is where we record all our care elements of work, and the BMS system, the SAP system, which is where all our finance system is, are both being upgraded in the next year. They should enable us to do things at a much more easier way. And actually what we want to do is be able to separate the costs out for individuals so they can understand which bit of the charge is related to which bit of care. Recently just had that conversation, for example, for transport, for example. And then people can also make choices about whether they want to contribute to that and whether they want that or whether they want to do something different, because it's about choice and control for people as well. So I think it's work in progress. I think there's a way to go, but we have got a financial team who would be happy to help people if they are struggling with that. The other side of that is we're also bringing together some of our benefits people to come together with that team to enable people to maximise their benefits, as well as look at what contributions they're going to make to their care. So more developments will happen in the next year to bring those things together.
Okay, Councillor Cox.
Sorry, just to come on to that, and actually I think that works well within the bringing the hub together, where we have a one-stop shop where everybody can get that information. We're doing something similar under the Armed Forces Veterans thing. You know, the hubs that are there, they're a one-stop shop, so you're not being pushed from pillar to post. So I think that could be a useful point to have that hub where there are people who can explain the charges and break it down for people in the community.
Yeah, one of the developments we want to do this year is we've talked about the integrated neighbourhood teams, but we're going to go much further in terms of neighbourhood teams and actually started to bring where there are separate teams together into those teams together. So there's a one single team for that population, and then they look after that population. And so actually, I want to be. I mean, I talk to people about saying I want the teams to know how many people live in residential care, how many people are in supported living. Are they okay? What sort of things are going on in that community? Not necessarily always counting things like, have you done your reviews? Have you done this? Because actually, it's not telling me anything about the quality of those things. What I'm interested in is actually making sure we start to think about having people having a good quality of life. Is the things that we're doing enhancing their life? If not, why can we do something different? Because actually, why spend money on something that's not doing that, really? So there is lots of ways in which we're going to develop that over the next year. So.
Okay, if there are no further questions, I will move on and ask Martin if there's anything to discuss.
No, nothing further to add. Just note that we'll get another performance report at committee in September, but you will get the next performance report circulated outside the meeting. So if there's anything you want to talk about, just let the relevant officers know. You'll be able to get an answer that way.
Thanks, Martin. And okay, if we can take a show of hands on the recommendations of the report. Thank you very much. We'll move on to our final agenda item, which is the work programme. Over to Martin.
Just to say there's been no massive changes. At the bottom section about briefings, information sessions, just note that some of those have been completed. And I'm sure with the CQC inspection, I'm sure once the outcome has been announced, we'll be able to get that briefing set up for members so you get to hear all about it in some detail. And then just also, if you have any suggestions for the work programme, bearing in mind that we are coming up to the point, scarily, what we'll be thinking about next year's work programme. If there's any issues you'd like to look at or go into the consideration for that work programme, let myself and the chairman know.
Bye.
Thank you, Chair. Martin, I just wondered if we had that conversation earlier about safeguarding training. There is also some LGA documents that help members with questions about what to ask around safeguarding and stuff. So having a session face-to-face or online with people, I can signpost you to that to enable you to share that with members in advance.
Okay, thank you very much. So just closing remarks I've made. The committee has considered three important reports that we've covered today: technology-enabled care, quality of the care market, and the current performance of adult social care and financial position of adult social care. I think it's fair to say that as members, we've welcomed the positive picture that we've been presented around care quality and safeguarding outcomes. But we do recognise that there are continued pressures within the market, and that's evidenced, particularly around the workforce challenges, and also the inspection regimen that's going off by the CQC, as well as by in-house within the council. We note that the progress made with the technology-enabled care is really good, and I think it's really exciting to see, and it's definitely helping residents live behind their own front door independently for much longer. And I think everybody, to speak for everybody here, that's a welcome development. The transition to digital systems, along with the adoption of AI, again, I find really fascinating. But I do note that there is a shadow side which we did discuss, and there is no substitute for human to human contact. That's, you know, we do talk about technology, but at the end of the day, you can't beat holding somebody's hand. With regards to the adult social care and performance target improvements, you know, it's good to see that we're in green for most of it. So obviously, where there are areas for improvement, then we look forward to seeing that. And finally, the committee has highlighted concerns around, as I've already mentioned, the backlog of CQC care reviews, the workforce pressures, particularly around sickness, long-term sickness, which is quite concerning, and particularly if people, employees are reporting things with mental health and stress. Hopefully, there's something that we can do to address that.
Can I just make a point on that though? Because I've looked into this, and quite often we think the stress is work related. Quite often, I think over 75% of it is non-work related. So things that are going on in people's lives that have a relation to stress, but not necessarily because of workplace.
Yeah. Okay. No, thank you for that. Thank you for that clarification. And yeah, I just want to thank everybody for their contributions, and look forward to seeing you in a couple of months. Thank you.